This meeting is being recorded.
Good afternoon and good morning to some of you, probably good evening to some of you as well. This is going to be recorded today, so if there's any information that you're having a hard time capturing, no worries, it will live on our YouTube channel. Before we get started, we are going to give everybody a few more minutes to get on. And we're going to ask that everyone keep their microphone muted, just so there's not a whole lot of feedback. I did go ahead and share 2 links that some of you may find helpful. One of them is for ClinVar, which is the National Institute of Health, where you can look up your specific VUS, variant of unknown significance. I believe Dr. Cannon might dive a little bit deeper into that as well. And then also the link for the no-cost genetic testing through Invitae, which is paid for by Xeris. And that is for United States citizens only, unfortunately. And it is, so ClinVar is the link for human genome database. All right, we'll wait one more minute. Right now we have almost half of our participants in. So again, for all of you that are just joining us, we are recording this today. So if there's any information that you're struggling to keep up with, it is going to be recorded and it will live on our YouTube channel. Also, before I hand this over to Dr. Cannon, we ask that everyone please keep their microphones muted so that that will keep the feedback from coming in and interrupting his presentation. And then also we are asking that when we do open it up for questions, that you limit your questions to 1 minute so that we can get as many questions in as possible. You can, once we ask for questions, feel free to unmute yourself, or you can also share your question through the chat as well. All right. Going to let a few more people in and we will begin.
Okay, I'll go ahead and start. Thank you, Monica, for providing this opportunity. I'm delighted to share this information and really try to empower you all to have more insight into the purpose of gene testing in periodic paralysis and to understand the results when they come back. So I have about, I don't know, 7 or 8 slides that I'd like to share to start the conversation. I think it'll set the stage. You'll find them useful. It's good these will be available for later review on the PPA website and on our YouTube channel. So we'll try. Oh, great! I see that I now have screen sharing capabilities. So hopefully you all can. We just move everybody's faces off. See the slides now. So let me just start off by describing a few aspects about the entire human genome. And, you know, what does it mean to look for a variant and try to understand whether that is in fact a mutation that is responsible for somebody's symptoms? So, you know, the human genome is huge. If you think about the letters that encode this information, you know, the A, T, C, or G, those are called bases. They make up the instructions for how to make proteins for all living cells. In the human genome, there are 3 billion of them that you receive from each parent. So a huge number of these letters. Most of the human genome is doing other regulatory things that we don't completely understand. And only about 1% of this 3 billion base pairs of genetic material, only about 1% actually is the instructions to code for proteins, like ion channels, where the defects reside in periodic paralysis. So it's a very small part. And by the latest count, we have a little over 19,000 identified genes in the human genome that code for proteins. So it's instruction set to make about 20,000 different building blocks for cells and tissues. So there's a lot of information there. The other thing you need to understand to interpret your gene test results and to understand what gene testing can do for you in your search to understand whether you have periodic paralysis or looking for confirmation is that there's a huge amount of natural variability in everyone's genome. As an example of this, there was a big international study where they sequenced the part of the genome that's coding for proteins, those are the exons. They sequenced that from over 60,000 people, normal people without disease, genetic disease, and put it in a big database. And they found over 7 million variations in that database. And in fact, when you looked at those variations, there were over 3,000 of them where those variations would destroy the gene so that it cannot function. Of course, you have 2 copies of each gene. And so these individuals did fine with the other copy. 1 copy was enough. And so even though they identified over 3,000 gene-killing mutations, 70% of these individuals had no symptoms or phenotype as a result of that. So you have to recognize that what might look like a catastrophic variation in a gene might have no consequence in terms of your health. That's a variability that you tolerate. The other way of looking at this variability is to see when one of these bases, base and nucleotide, are 2 different names for the same thing. It's one of these single letters. So in many cases, there isn't a radical change in the genetic material. There's a substitution at a single base or a single nucleotide. And something that's variable, its form, what it looks like. There are many forms. That's what polymorphism means. Many forms of the genetic code at the site of a single nucleotide. So these single nucleotide polymorphisms are the so-called SNPs that you hear about when you learn about genome results and what comes back from 23andMe or Ancestry and things like that. So these single nucleotide variations occur at about every 1,000 bases. So you have 4 million variants, each of us, in your genome at the single nucleotide level. And if you look at those parts of the genome that are coding for proteins, of these 4 million variants, about 20,000 of them occur in exons. So bottom line, where am I going with this? When you're thinking about the variants that come back on your gene testing result, and how do I interpret this in terms of susceptibility to disease, periodic paralysis, or anything else? Remember, all of us have about 20,000 variants in the coding regions of our genes that are making proteins. So this, I'm trying to give you a sense of the challenge for the interpretation of the gene test results. The tests are very accurate. The companies that do this are very high quality. But just because you find a variation, that's just the beginning of the journey here. You have to interpret what that means. So let's talk about the genes for which variations are found in association with periodic paralysis. There are 3 main genes. We'll go over this in a minute: a calcium channel gene, a sodium channel gene, and a potassium channel gene. These individual genes, to give you a sense for how big they are, here's a cartoon of a chromosome, the condensed genetic material in the nucleus of a cell. That's where all the instructions for how to make everything is in the nucleus of the cell. So if you were to expand this, This is the long strand of DNA, the so-called double helix. And when you look at all of these nucleotides or bases along this string of information here, the gene has segments that eventually give the instructions for how to make a protein. Those are called the exons, and they are interrupted by introns. So there are these little skips, exons, introns. So when your body reads these instructions, it makes a messenger RNA that has parts that code for proteins and parts that don't. Then this gets processed and spliced to the mature RNA. It makes a protein, makes the ion channel, and helps your muscle fibers be excitable. I'm going to this detail to remind you that these genes are huge. So if you were to do not just the exomes, but whole genome sequencing or sequencing just of the genes, there are 90,000 bases in the calcium channel gene. You're going to find a lot of variations. Many of those variations are going to occur in introns. That's not going to affect how the protein is assembled. So those are going to be benign. So I'm trying to give you a sense for why you tolerate a lot of variance, a lot of variations without an effect. There's about 5,000 base pairs that are coding for the critical parts that make the protein for a calcium channel or a sodium channel, and about 1,200 for the potassium channel. So let's talk about, I'll give you a chance to answer your questions, I promise, to ask your questions. Let's talk about the genes that cause periodic paralysis, because the gene testing panels and the results you get back screen many genes, or if you do whole exome sequencing, you're asking the company to look at 20,000 genes. And so you're going to get a lot of information coming back at you. But this is an up-to-date summary of those specific genes, these funny sequences of letters and numbers. These are the shorthand name for all these genes. There are only a few of them that are clearly established to be causes of periodic paralysis. And so, as you know, there are many different clinical variants of periodic paralysis. Roughly equal numbers, maybe a few more commonly occurring hypokalemic periodic paralysis. The overwhelming majority of genetically confirmed cases of hypokalemic periodic paralysis have pathogenic variants or mutations in either this particular calcium channel, CA-CNA1S, or this particular sodium channel, SCN4A. I'll just go, in bold are the most commonly occurring ones. For individuals with hyperkalemic periodic paralysis, it's a little simpler. There's a single gene, the sodium channel gene, SCN4A, that accounts for all of the clearly established variations, gene mutations that can cause hyperkalemic periodic paralysis. In the Anderson-Twill syndrome, which is periodic paralysis with heart arrhythmia and particular features of skeletal bone formation, shape of the face, curvature of the fingers, height, length of the neck, how wide set the eyes are, etc. In this cluster of symptoms, the most clearly identified causative gene defect is in this potassium channel, KCNJ2. Very rarely, for a family in Japan, there was another type of potassium channel where these gene products, the proteins interact with each other. So there was kind of a crosstalk here, but this is very rare. Similarly, the group in Germany, Karen Jerkott-Roth, working with Frank Lehman-Horn, found one patient with another type of potassium channel mutation that had hypo-PP-like clinical symptoms. The point, of course, each of you is an individual. How a variant affects your health is important to look at it on an individual basis. But we need to recognize that even in this rare disease space, these genetically confirmed mutations that cause periodic paralysis, these are rare. But in this space of looking for disease-associated mutations, there are extremely rare cases found in one patient in the world or one family in the world. Or there are other genes that are not classical case of ion channels that we can understand how these clearly regulate the electrical excitability of skeletal muscle fibers. Because for periodic paralysis, every well-established case is a problem with the electrical excitability of your muscle. So these ion channel gene defects, they make sense. We can connect the dots. Through efforts to search, there are some families who have symptoms that look a lot like periodic paralysis, but mutations weren't found in these classical ion channel genes. So research labs expanded the search. And so some very convincing variants were found in something called the ryanodine receptor. It's a calcium release channel that works on the inside of a muscle cell, or in a subunit of a pump that helps keep this balance of sodium and potassium salts regulated for the inside versus the outside of the cell. Or a couple of other genes that regulate how those messenger RNAs move in and out of the nucleus, or how your energy powerhouse, how your mitochondria work in cells. While it's important to acknowledge that these variants caused symptoms that had overlap and shared features of periodic paralysis, these were all atypical. So for example, the onset was later in middle age, not typical for classical periodic paralysis, or this individual had seizures, difficult to control seizures, as well as periodic paralysis. And this was one individual in the entire world. So you have to recognize that in the medical literature, it's important to acknowledge these overlap syndromes so that we can advance our understanding of human biology and disease. But these are not likely targets to go look for why your symptoms might be attributable to a variant that is a cause of periodic paralysis. Again, worth looking, but you need to be aware of how rare they are. So let me just finish up and let you ask some questions by talking a little bit about these classical cases where pathogenic variants or mutations have been found in these classical genes responsible for periodic paralysis. And one of the big messages I want to get out there is that really a few mutations keep recurring over and over again in different families, unrelated families. And these few mutations account for the vast majority of genetically confirmed cases of periodic paralysis. So I'm going to show you a table from this excellent study from Mcmanus group in London. It was published in Neurology now 9 years ago. And the national healthcare system in the United Kingdom is a wonderful infrastructure for trying to capture all the individuals with clinically convincing periodic paralysis and look at what their genetic test results showed. So I know you can't read the fine print in this table, but this table is showing the confirmed cases of periodic paralysis. And what I'm highlighting here is in all of England, in their families with periodic paralysis, hypokalemic periodic paralysis, they had 47 families, independent families with classical symptoms of hypokalemic periodic paralysis. And for 43 out of those 47 families, 2 calcium channel mutations accounted for 43 of those families. The R528H mutation is the most commonly occurring mutation in hypokalemic periodic paralysis in this calcium channel, and mutation at R1239. This is an arginine to histidine substitution. So it's a single amino acid substitution. So again, each person is an individual. We're mindful of that. Of course, we will look for any variant. It's important that now the technology sequences all the exons and looks for any variant that would cause a missense mutation of the amino acid. But you need to recognize that the overwhelming majority of cases, well-recognized cases, are accounted for by a few mutations. Similarly, in hyperkalemic periodic paralysis in England, there were 48 different families. Classical hyper-PP, very well defined. And again, 2 mutations in the sodium channel accounted for the majority of those cases. 43 out of 48 families had one of 2 possible mutations. So again, I want to emphasize the consistency of what classic typical periodic paralysis looks like, the association between specific gene mutations and confirmation of the disorder. Let me leave you with 2 rules of thumb, because these are the easy cases, right? If you fall into this category, you got a clear result from, Invitae or some other gene testing service. Your medical team has an answer for you, and these, are not the cases of people still searching for an answer. So let me touch upon what to do if your situation isn't one of these very clear-cut cases. So again, I'm happy to assist any of you if you're trying to interpret a variant. The best way to do that is to submit your question and to ask the experts, or work with your own local team of healthcare providers. But if you still have questions, that's the best forum in which to try to get additional information. But I know people like to be empowered to do their own sleuthing, look on these gene databases. So let me give you 2 useful rules of thumb. First of all, if there's a variant found in your gene test results, remember, for that variant to possibly be relevant for periodic paralysis, that variant must happen very infrequently in the general population. Why? Because periodic paralysis is a really rare disease, right? We know that something like on the order of, at most, 1 in 100,000 people has periodic paralysis. So maybe 3,000 to 5,000 individuals in the United States clearly have clinically definite periodic paralysis. And the disease is inherited dominantly. You only need 1 copy of the mutant gene to be symptomatic. So therefore, any variant that's a mutation, it's a pathogenic variant that's causing periodic paralysis, can't occur any more commonly in human genomes than about 1 per 100,000. If it did, if it occurred once in every 1,000 genomes of randomly sampled individuals, then 1 out of 1,000 people would have periodic paralysis. But that's not what's happening. So when you see a variant, and in fact, Invitae, they ignore all these variants. You might have a variant that occurs 1 in 100 people, 1 in 1,000 people, 1 in 2,000. They throw those out. That's junk. That's noise in the background. Because by definition, it must be a very rare variant, because periodic paralysis is a very rare disease. So if you go to ClinVar or some of these genome databases I put in the chat, Genome AD is a huge database of all the variability in the human genome. You'll see that there are a lot of variants that occur frequently, and we know these don't cause rare diseases like periodic paralysis. One last word, and then you can ask your questions. Not only should you look at how frequently this variant occurs, but what's the consequence of that variant? So some variations, they don't change how the instructions are read. So it turns out to specify which amino acid goes into the protein, into the ion channel. The body, it reads 3 letters in a row, ATG. And those 3 letters code for 1 amino acid. Well, there can be a little wiggle room in that. So there are several different variants. So you can have a change in the bases in the nucleotides, but it doesn't change which amino acid that codes for. So that would be a benign variant. Another thing to realize is that in hypo-PP and hyper-PP, not in Anderson-Tawil, but in hypo-PP and in hyper-PP, our understanding of what causes these diseases is a pathogenic variant that alters the function of the ion channel. It's an altered function. It's a change of function. It's not a variant that, you know, wipes out the gene and kills that copy of the channel. In fact, we know from sequencing many individuals, both normal and related to individuals with recessive diseases, that you tolerate missing one copy of your calcium channel gene or your sodium channel gene associated with hypo-PP or hyper-PP. So companies that screen for genetic variants, they might find a change in your calcium channel genes and say, whoa, this is a problem. Here's a variant that interrupts the message. It's going to cause a stop. You're not going to make a full calcium channel. Well, you would have to report that as a pathogenic variant. This is not a functional copy of the sodium channel gene, say. But remember, you have two copies, one from mom and one from dad. And we know you only need one functional copy to be asymptomatic and have normally functioning muscle. So bottom line, if you're considering I have hypo-PP or hyper-PP, and I have a pathogenic variant that, you know, causes a null or a frame shift or destroys the gene, that's not the answer for you. It's mutations or variants that alter the function of the gene, not ones that wipe it out, that are possible causes of hyper-PP or hypo-PP. I know this is diving to the weeds, a little bit of technical details, but I want you to appreciate the perspective and analysis that these companies use, your healthcare professionals use, and we use to try to help you understand what it means because I have a variation. And despite the frustration that's out there, because I know there's a lot of variants of unknown significance and a lot of unknown situations, we really are trying to bring to bear a lot of these insights to help with the interpretation of your gene results. So I hope this is useful. You can play it back as a resource, and I'll let everyone share their cameras with their questions if they want. I'm happy to answer any questions that the group may have.
Real quick, Dr. Cannon, I'm going to see if there's anyone who needs to join us. Let's see.
So I know I was empowered as the host to share slides, so I was trying to admit people who were in the waiting room. So hopefully
Perfect.
everyone has had a chance.
I believe everyone is here. Okay, so yes, we can go ahead forward with some questions. Just remember to unmute your mic.
I have a question. So I got back genetic testing results from Invitae. I was seeing a Dr. Johns Hopkins, Dr. Rhoda, and I got the testing done. I mean, I've been dealing with potassium episodes since I was 18 years old. It kind of trailed off in my late 30s, early 40s. My mom ended up in a wheelchair. My grandma was in a wheelchair. My uncle was in a wheelchair. I had my 3 sons tested. They all tested positive for this variant, this common variant, one of the ones that you mentioned in the British study, the top 2 of the CACN. So in those test results from Invitae, and it shows that mutation, that common mutation in our results. Is it possible there's other mutations that weren't reported because they kind of fell outside of their focus area?
Yeah. So it's a great question. So, you know, in medical practice, we like to use parsimony, right? If you find one good explanation for why someone is affected by a disease or a symptom, disorder, usually that's going to be comprehensive and you don't need to look further. We don't put blinders on. So the good thing about the technology for gene testing now, certainly Invitae and other quality companies, CLIA approved companies, they sequence all of the exomes of the relevant channels for periodic paralysis. So the calcium channel you mentioned, sodium channel, and potassium channel. And they will report if there's more than one variant. Okay. You raise the interesting question of, okay, I have a well-recognized, commonly occurring variant that can cause periodic paralysis, but my symptoms are a little different from my uncle's that are a little different and his family. So there can be so-called modifier effects that are inherited. So you can have variations in other genes, this variability we've been introducing to, okay? And those variations in and of themselves might have no consequence for the average person, right? But if you combine that variation with a disease-causing calcium channel mutation, then suddenly your periodic paralysis is a little different from other people's because there's a modifier effect. So that's well recognized in genetic analysis of human disorders. So there can be modifier effects. For example, Monica's story that we shared at the PPA meeting last fall, in her family, some individuals carry a variant in the chloride channel and some in the calcium channel, excuse me, in the sodium channel. And only when the two of them come together in the same individual are there symptoms. So that's an example where, yes, sometimes you need to look at more than one gene. And so the interpretation can, quickly become a little bit intricate. But, in your situation, I would say with high confidence, again, you illustrate one of the classical scenarios: multiple individuals affected in a family, consistent segregation where the pathogenic variant is found in people who have symptoms. You didn't say this, but I presume is not found in others who are unaffected. So those are the really classical cases. It also illustrates the added value of families who come together on this and want to have multiple individuals tested. So this can be particularly helpful if a so-called novel variant, a variant of unknown significance, is identified in somebody's family. One of the tools to try to figure out the significance of that is if individuals, both affected family members and unaffected, are willing to also have genetic tests performed, and then you can compare and see whether there's segregation, co-inheritance of the symptom in a particular variant. Can be very helpful. I'll also mention, some people might say, why get gene testing? There are half of my relatives are affected in 3 generations. We know this is periodic paralysis. I respond to potassium. Why get tested? Well, first of all, it's an important form of confirmation that's accurate, that's covered by many insurance companies, or uncovering periodic paralysis, Invitae program, it's no cost to you. Accuracy is important here because even the most astute clinician, world expert in periodic paralysis, myself, Robbie Tewill, Frank Lehman-Horn, Mike Hanna, none of us can look at an individual and talk to you and learn about the way this disorder affects you and say, oh yes, you have R528H in the calcium channel. There's not that specificity in the clinical presentation. But by having this information available from families who get tested and share that, we can try and improve the information we can provide for you. What can you expect? Do people with your variant have favorable responses to carbonic anhydrase inhibitors? Do they respond favorably to potassium? Later down the road, we want to do gene therapy. To be eligible for gene therapy, we need to know which variant somebody has. So there's a lot of added value. I'll get to probably a question in the back of many people's minds, and you were kind enough to share that individuals in your family have had loss of ambulation later in life. This is, of course, a major concern for anyone with periodic paralysis. One of the first questions we, not just our lab, others asked was, is there a particular association with particular variants and risk of this late permanent muscle weakness that can interfere with ambulation? And as many of you are probably aware, and as you've read the literature, we're now confident that all the different clinical variants of periodic paralysis, unfortunately, can lead to late permanent muscle weakness. So you can't escape it by having hypo versus hyper PP. And if you look hard enough and carefully enough, some individuals and clinicians feel that over age 60, probably about 80% of individuals with periodic paralysis have objective detectable weakness on quantitative muscle strength testing. So you can see it. So it's fairly common. And we're still making the associations between particular variants. We have not identified either hotspot variants that, oh gosh, this one does not have a wonderful prognosis about the risk of permanent muscle weakness, nor have we seen variants that said, oh, you're very fortunate, you're going to escape this consideration. Okay. So, while that might be disappointing at this stage, we're still at the information gathering period. And so getting this genetic information, sharing it with your healthcare providers, we assemble these into large databases, are helping us put this together. I'll give you another example of, and I'll make sure people have a chance to ask questions, why gene testing can be helpful. In hypo-PP, even the best of us, the most astute, experienced clinicians with periodic paralysis, cannot look at a family and say, oh, you have calcium channel-based hypo-PP or sodium channel. But the gene test results will clearly distinguish that. And we know from again, looking at families and what happens when we try interventions, that individuals with hypo-PP and the sodium channel mutation are more likely to possibly have an adverse event, unfavorable outcome from taking carbonic anhydrase inhibitors to try to prevent episodes of periodic paralysis. So knowing your gene variant can influence the choice of medications that your healthcare team may recommend. So again, while these are not commonly occurring scenarios, they do happen, and information is power. And again, I would encourage individuals, because the accuracy and the availability and the cost are all low threshold now to get gene testing, to go for it. We respect the fact that for personal reasons, certain members of your family, perhaps religious reasons, some people don't want to have gene testing. That's their right, of course. But if those aren't barriers to you, there's a lot of empowerment that can come with the confirmation of genetic testing. I should let Mohammed ask questions.
Real quick before his question, I believe there was a paper from the National Institute of Health that talks specifically about which genes and what you were speaking about when it comes to treatments, that I'll try to post on the chat so that everybody has a link to that.
Terrific. Mohammed, you want to unmute yourself and you can just ask a question?
Yeah, can you hear me, sir?
Yes, absolutely.
Hey, good afternoon, everyone. So I've never had the genetic testing. I was hospitalized a few years back in Atlanta, Georgia, with total paralysis. Maybe I had too much beer the night before. That's another story. But the point is, I was totally paralyzed, and I got into the emergency room, and by fluke, they tested my potassium level, and I was at 1.9 to 2.0, and the young lady that was doing everything, I say young lady, but it was not actually, she was a physician, I asked her, says, why don't you think it's 1.8? And she pretty much said, because you're not in the morgue, you're up here in the emergency room. And that kind of scared me. But I've been seeing a neurologist off and on, and I found that they really didn't know anything about this condition. So I guess with all that, my question is there anyone in Central Florida area that you could recommend or point me in the direction to that would have some experience in this?
Yeah, so there are lists also provided by the PPA and on the website at the University of Florida at Gainesville. There's several in the Department of Neurology who are very experienced. Your comment raises an interesting point. Though this is a rare disease. Again, 1 per 100,000, maybe 3,000 to 5,000 affected individuals in the United States. Many neurologists have never encountered a patient with periodic paralysis. And so it's a challenge and a barrier to the diagnosis. I will also comment, because this relates to gene testing and what we're talking about today. Your scenario, I was fine. I had then one really severe episode of weakness with an extraordinarily low potassium. I was in the emergency room. The first thing to check is your thyroid function. The most common cause of severe weakness with an incredibly low potassium, often coming as a young adult, as a sporadic case without other affected family members, is thyrotoxic periodic paralysis, especially common in individuals of Asian ancestry or Latin American, actually, and much more common in males than in females. So that's an important one to exclude, because if you fix the thyroid disease, the hyperthyroidism, the risk of recurrent attacks of weakness completely goes away. That's an important exclusion. I'll also, let me enrich the conversation we had of gene testing. And again, I thank Bill's comment for talking about a classical case and why that's still valuable. Many of you are probably struggling with variants of unknown significance, or maybe not even having any variants detected. So where do you go next in your journey? My personal opinion on this is there are other pieces of data you can put together to try to impact the confidence level with which a diagnosis of periodic paralysis can be made. So of course, there's the nature of your episodes, how frequently they occurred, when they happened, what are the trigger factors. But other really important things are multiple people in your family, blood relatives, affected with similar symptoms? That's really important, because classical forms of periodic paralysis are dominantly inherited, relatively high expression. So if you carry the mutation, you're generally going to be symptomatic. The caveat there is in some cases, women do not have as frequent or severe episodic attacks of weakness as the males in the family. The other thing, though, if you're searching, are my muscle symptoms attributable to periodic paralysis? My gene testing is a variant or nothing, it's ambiguous. Go to a neuromuscular specialist who is familiar and experienced with the electrical tests that can be done in the outpatient office to look for corroborating evidence of periodic paralysis. This is the so-called Mcmanus long exercise test, or the CMAP, compound muscle action potential test. So this is a test where the physician can, in the outpatient setting, measure the electrical excitability of your muscle, small muscle in your hand, have you exercise voluntarily for a few minutes and then relax, and they monitor the change in excitability of that muscle over about 45 minutes. If after exercise, there's an impairment of the excitability of your muscle, and it has to be clear, research criteria, you have to lose 40% of the amplitude of the electrical response. That is very strong corroborating evidence that you have a functional defect of the electrical excitability of your muscle that's consistent with periodic paralysis. So again, in this search for expanding our repertoire of disease genes, and should we keep looking, should we do whole exome sequencing? Well, I would reserve that for those cases where multiple individuals are affected, the symptoms are classical for periodic paralysis, and your CMAP lung exercise test is abnormal. If you have all of those features, which together are strong clinical evidence for a convincing diagnosis of periodic paralysis, but the gene test is still ambiguous, that's when we need to scratch our heads, think about other genes, go outside the box a little bit. On the other hand, if you're in the situation where other members of your family are not affected, my symptoms are a little strange because it only comes on my left side. It tends to, be associated with other features that are not classical, associated with periodic paralysis. And I got back variants, but nothing else that's informative. Well, I'm not sure that your symptom complex is necessarily periodic paralysis or even an atypical variant. And we all need to be open-minded. I mean, the PPA community and myself are always happy to help you in your journey and to work through these pieces of data. But the point I want to make is don't get stuck and anchored mentally in some variant of unknown significance that's in a gene that's rarely associated with periodic paralysis. You and your healthcare team need to remain open-minded that there might be other reasons that you have these symptoms. And so again, you should stay open-minded about that.
So I was able to find the link for the drug treatments and the different types of periodic paralysis, and who, as you were mentioning, some people benefit from it more depending on your actual genetic mutation. Real quick, there was a question that just popped up. Did you want me to read it to Dr. Cannon?
Oh, I see in the chat here, yeah, so I can read it from Noreen.
Yes.
She's 62 now. My first full body paralysis came when she was 44. So that's a little older than usual. Since then, I've had many attacks, like 150 of them, full body paralysis lasting several hours if no potassium is administered. Therefore, I have a clinical diagnosis of hypo-PP and gene testing done twice with no variant identified. The last test was in 2015. So I'll comment right now. It's important to think about when your gene testing was done, because in the early days, this was an expensive research-only technology that research labs were doing, not commercial labs. Again, these individuals did quality work, but it wasn't practical to screen the entire gene. They would look at hotspots. So if in the 1990s, Frank Lehman Horn's lab or Eric Hoffman's lab or, Mike Hanna's lab screened your DNA and didn't find anything, well, the tools weren't there yet to screen everything. And not only now is the screening more comprehensive, but the technologies to look for subtle changes are even better. So 2015, though, is pretty good in terms of most recent screen. Okay, so far, no permanent muscle weakness detected. I have 2 adult daughters, and to date, they show no symptoms. So living successfully, but I wonder if I should try testing again. What are your thoughts? Again, if the fine print of your gene test result, it was whole exome sequencing of the candidate genes, the 3 that we mentioned, CACNA1S, SCN4A, KCNJ2. Those are the sweet spot for looking at variants that cause hypo-PP. If you had whole exome sequencing in those, I wouldn't look again. Now, if you have, I'm sorry, I'm just going back to your, so your daughters are fine, but no one else in the family is symptomatic. I see you shaking your head. So, in that case, in your situation, I don't know if you've had the opportunity for the CMAP exercise test, but that could be very helpful. Let me expand upon that a little bit by saying, if the CMAP exercise test is abnormal, in other words, it's consistent with periodic paralysis, That is very informative because so-called false positives essentially are unheard of. Some people think they never occur. So if you get an abnormal result, that's very helpful. If your CMAP exercise test doesn't show an abnormality, that's nice to know, but it's harder to interpret because the sensitivity of the test is probably only about 60 to 70%. In other words, what do I mean by that? So an individual who has absolutely classical hypo-PP, the R528 calcium channel mutation, if that individual goes in and has a CMAP exercise test, only about 70% of the time of testing days would that test be abnormal. So it might be fine one day, you go back another day, oh, it's abnormal, another day it's abnormal, oops, now it's fine. And so this is just the variability of human biology. So it's a laborious test, it ties up the EMG machine for an hour to do it. A lot of neurologists aren't super excited about doing the test. I would use that as a tool to try to understand, whether you should expand your search. The other things I would just add in your personal situation, again, thank you for sharing your story with everyone, that with the first attacks coming later, now being 62 and not having anything you recognize as permanent weakness, those are favorable features of your situation, I would say. Again, because the classical case hypo-PP onset is usually around late childhood or puberty. The episodic attacks are a real problem in the teenage years in the 20s. Sometimes they slow down, but they get replaced by longer lasting episodes. I'm just not quite at 100%. Then you're 40 and 50. Problems walking up the stairs, need to use your arms to get up out of the chair. Those are the classical presentation of periodic paralysis with permanent muscle weakness beginning to come in.
So Dr. Cannon, real quick, as we're talking about ruling it in or out clinically, we get a lot of people talking about how they have no food triggers, that nothing they eat triggers an episode. Is that a key indicator that they possibly don't have some form of periodic paralysis?
Yeah. So the trigger factors are a very prominent feature of periodic paralysis. So very early, 100 years ago, in our understanding of these disorders and the first descriptions in the medical literature, it was a distinctive feature before anyone understood the disease of how clinicians would key in on the fact that, oh, this might be this unusual entity, this rare muscle disease called periodic paralysis. Again, this is the value of gene testing. When you now can look at large groups of individuals where the classical story, multiple people affected in the family, we know this person as an individual carries the pathogenic variant, and you ask that individual, do you have recognized food triggers? Do you have exercise? It's not 100%. The numbers are somewhere between 40 to 60% of individuals will say, yes, that's a trigger for me, and so forth. So another way to comment on your question is if those classical triggers are absent, that doesn't exclude the possibility you might have periodic paralysis. Again, to make the diagnosis and help provide advice for symptom management, you really need a holistic approach of putting all the pieces together. What trigger factors do you have? How severe are your episodes? When did you begin having them? Are other family members affected? Do you have a pathogen? You put all those together to come up with a treatment strategy. And the trigger part, again, it can be an important piece if your medical team is struggling to establish diagnosis. So having it present, it's in the plus column. If you have it, it's like, okay, that's a check mark. We need to keep into the realm of realistic possibilities. You may have periodic paralysis. On the other hand, suppose you have a family that's known to have periodic paralysis. Gene mutation has been found. It's the R528 mutation. You're not particularly enthusiastic about gene testing. You didn't get it. You've had days where your strength isn't great, but you don't have classic triggers. That doesn't mean you don't have periodic paralysis. You could definitely have periodic paralysis, and you need to be aware for that. You don't, even within the same family, with the same variant, some people are very sensitive to food triggers. Other people who definitely have the disorder may not share the sensitivity to those triggers. And that's just the variability of biology. And so you need to be aware of that.
So we have another question that came in through the chat.
All right, let me just scroll a bit here. I have a test showing a problem with the transketolase enzyme related to thiamine problem. I know thiamine IVs have caused my nervous system to suddenly work normally. I had only 3 episodes of PP, but neurologist suggested maybe calcium ion channelopathy. I know the inability to use thiamine affects electrically excitability of the nervous system. So, vitamins are cofactors that help many enzymes work, that can have a whole host of effects on the body. Many parts of the nervous system are vitamin sensitive. Many of you know B12 deficiency, for example. You can have spinal cord and peripheral neuropathy problems. So in general, there isn't a definitive connect the dots association with particular vitamin deficiencies and susceptibility to periodic paralysis. But your comment raises an interesting question, and it's open-mindedness about understanding where somebody's symptoms may come from. And these overlap symptoms, or syndromes, I should say, overlaps a cluster of symptoms between periodic paralysis and something else. So what's that something else? Maybe hyperflexible joints, like an Ehlers-Danlos syndrome, right? And for some of those individuals, they may not have an identified variant in an ion channel, like a calcium channel. And so the question is, though, maybe they have variants in the genes encoding connective tissue, like collagen. So how do you put that together? And again, this is where we need to be open-minded, because while I am convinced, having spent now 33 years studying periodic paralysis, my whole career, classical periodic paralysis is caused by intermittent electrical disturbances of skeletal muscle, period. That is where periodic paralysis comes from. So there could be many reasons why an individual has intermittent disruption of the electrical excitability of skeletal muscle. The most common, well, this is always rare diseases, but the clearly established ones, the one we understand, are these pathogenic variants in ion channels. Why? Because ion channels let electrical currents flow in and out of muscle. They regulate the electrical excitability of muscle. That makes sense. But there's a whole complex biology of how a muscle cell maintains its electrical excitability. So you have to have properly functioning ion channels, but those channels have to get to the right place. So other parts of the cell that regulate the trafficking, or they have to stay localized in the right place. So other connective tissue components like collagen can anchor ion channels and determine where they sit. Or other genes like regulating the pumps, regulate the ratio of salts in and out of the cell that could affect excitability. Or other genes code for things that regulate how RNA gets processed. So in myotonic dystrophy, the myotonia comes because their chloride channel RNA isn't spliced properly. So it's not a mutation in the channel, it's a mutation in something else that affects how the instructions to make the channel get bundled up. So again, going back to your issue of thiamine and other genes, and what about genes aside from ion channels? Yes, there could be biological connections where other networks of genes and functions are connected in this big web of, interconnected biology of maintaining a healthy muscle cell, that at the end of the day cause someone to have intermittent disrupted electrical excitability of their muscle. And then they're going to have symptoms of periodic paralysis. From my perspective, if that's the scenario, again, there's the final common pathway, disrupted electrical excitability of your muscles. If that is occurring in a significant way, the CMAP exercise test should be abnormal. So that's why, for me, the key piece of objective information that would certainly cause a scientist and a physician scientist to, put on your thinking cap and scratch your head, and we got to broaden our scope here, is if somebody has, intermittent weakness and abnormal electrical excitability of their muscles by the CMAP exercise test, but the classical ion channel screens don't reveal a variant. Okay, that's where we need to look at, whole exome sequencing, and that requires not, the terrific neurology clinic down the street, or even the university neurology clinic. That requires, very sophisticated, bioinformatics and genome research laboratories to work out those problems. But these are the kind of key features and unusual scenarios that cause people to look harder and look for more. So again, where I was going with this and trying to answer your question and Monica's comment is that there is biological plausibility that there could be variants in something other than an ion channel gene that could cause symptoms that are consistent with periodic paralysis. Yes, it's out there. But these are going to be atypical cases.
So Dr. Cannon, real quick, we have two other questions that come in, but real quick, just to follow up on hers. So conditions that can have that overlap, right? The EDS, I believe myasthenia gravis is one of them. There's one, I believe, that has to do with the amino acids as well. It's losing my, I'm not quite able to find it in my brain right now. But the importance of getting the proper diagnosis with the EDS, with the myasthenia gravis, or these other conditions is, under those circumstances, the periodic paralysis would be secondary, correct? And you would need to fix or treat the primary condition.
Yeah, so you bring up a really good point, is the recommendations that we have for classical periodic paralysis. Potassium supplementation, carbonic anhydrase inhibitors will likely be totally irrelevant to these other disorders that have features that have episodic weakness as part of it, but it's not through the same mechanism. Your question has stimulated me to make another comment. Let's take the RYR1 situation that people are focusing on a lot. So RYR1, the ryanodine receptor. There's a whole biology, there's an RYR1 society. It's been known for many years that variations in the RYR1 gene can cause a lot of muscle diseases, very common muscle diseases, congenital myopathy, central nuclear myopathy, multi-mini core disease, malignant hyperthermia, lots of different diseases. Most of these are so-called myopathies, which means often present from birth, fixed defect of muscle that's severe enough where someone might need assist devices to walk, or the muscle weakness is so profound it affects formation of the skeleton and things like this. Every once in a while, some of these myopathy cases, classic myopathy, RYR1 mutation, yes, we're talking about congenital myopathy. But then this person, age 20, age 30, has a few funny episodes where the weakness is much worse than usual for 2 days. And then a year or two later, they have another episode, but that's it, their whole life. Well, what do you call that? So some individuals look at, yes, I have a RYR1 muscle disease, It's mainly congenital myopathy, but I had 2 episodes of transient weakness that with spontaneous recovery. Is that a variant of periodic paralysis? It becomes kind of a semantic argument here, right? So again, there's a lot of gray areas on the edges of this and what you want to put together and call periodic paralysis. Because the mechanism underlying those, their response to our recommendations for symptom management will likely be very different in those situations. And, I'll just make an editorial comment. One of the blessings and one of the curses of periodic paralysis is accessibility to potassium salts. So the blessing is you can literally go get it as a salt substitute or a supplement without a prescription. And the blessing is it's readily accessible and helps many people. The curse is that you need to watch out for escalating dosages and getting into trouble and actually hurting yourself, or not having a confirmed established diagnosis of hypo-PP, and all this potassium salt you're taking is only going to potentially get you into trouble and create a lot of extra work for your kidney to release it in the urine. So again, mindfulness, move slowly, do things in moderation, be really objective, what helps, what doesn't clearly help, and we'll work with your healthcare professional team. And again, if you have atypical periodic paralysis, it doesn't fall into the classical scenario, maybe your potassium was low-ish one of the times you went to the emergency room. Maybe it was 3.5, even 3.2. To me, that's not the bright flashing lights. I have hypo-PP. You're at the low end of normal. All of us, people who aren't affected, are going to have fluctuations in potassium. So there's a natural tendency. People want to be proactive and improve their health. I've been bothered by intermittent weakness. One time in the emergency room, my potassium was 3.2. This is annoying to me. What the heck? I'm going to start taking potassium salts. Be careful. Be careful what you do, and work with the team to get a firmly established diagnosis, because you can get yourself into trouble.
So we have a question from Bill, and then we have another one after his from Trudy.
Okay. So Bill has had progressive muscle loss for the past 6 years, now 56. I'm guessing I've got about 2 more years before I may need a wheelchair. I've read the story about Inspira. It's a potassium-sparing diuretic used for high blood pressure. Patients in Europe gain some muscle strength. I also started on high blood pressure meds in the last 12 months. Would it be beneficial to discuss Inspira as an option for treating my high blood pressure and improvement? So, so your comment brings up a couple of important questions. So, important points. In the natural history of periodic paralysis, classical cases, confirmed diagnosis, gene testing, there is this trend for the acute episodic attacks to get less frequent, to be kind of fuzzy on the edges, to last longer. I had a bad couple of weeks, and there can be this blurry, fuzzy zone of, am I transitioning to permanent muscle weakness, or is this just a prolonged episode? And I would suggest individuals remain open-minded that this is a prolonged reversible episode and not permanent muscle weakness. This first became apparent way back in the 1960s and 70s when Birch Griggs and his colleagues tried Diamox, acetazolamide, in patients with periodic paralysis. And what they found is that there were individuals who said, I was kind of at 80% for months. And I thought, this is just it. I'm not going to have a full recovery. And they went on acetazolamide and had improvement, definite improvement. And the case, Bill, that you're referring to, there's a very very famous, wonderful outcome of one of Frank Lehman's Horde cases where I believe this was with Frank Weber, and they were doing MRI studies of swelling and edema, water collection in muscles and periodic paralysis. This individual had been wheelchair bound for a long time, had edema in her muscles in the MRI, and they said, well, let's use one of these diuretics, Inspira, and see if the swelling resolves a little bit and maybe your muscle function will improve. And she got up out of her wheelchair. Now that's a spectacular case, and it just emphasizes the point of not giving up and considering the medications like carbonic anhydrase inhibitors, like Inspira or Eldeprone, and things like this, that are these potassium sparing diuretics that have resulted in some degree of reversibility. So always important to stay open-minded about that. And yes, I would discuss with your clinicians whether you can get a 2-for-1 managing high blood pressure with Inspira and also having a more favorable profile for maintaining sustained higher levels of serum potassium, helping with your hypo-PP. Maybe I'll go to Trudy's question. Are people getting worse as they get older, partly due to the addition of medications such as cholesterol, blood pressure, et cetera, that we use with age? Great question, Trudy. So the general principle that aging is tough is I'm beginning to understand now, and personally, but no, in all seriousness, the natural history of biology is right. We accumulate reduced capacity for regeneration, our skin, our muscles. You can have irreversible degenerative loss of heart function, brain function. And so this is all just part of the natural evolution of life itself. And what happens is what might be a really slow, prolonged process, then all of a sudden becomes symptomatic because you cross a threshold. This happens with dementia. This can happen with loss of ambulation late in life. So Trudy, you raise an interesting point that you can have, if you will, compounding multiple factors that can make the process that might be putting someone with periodic paralysis at risk for late, slowly progressive, permanent weakness to now become symptomatic because, oh, you were on that statin, that cholesterol lowering drug that also was stressful for your muscle and your liver. And now you're more symptomatic than you would have been. So yes, good medical care and prudence is to look at all the factors that might contribute to impaired muscle function, weakness, and to optimize all of those in an effort to have a high quality of life and standard of living. So, someone with periodic paralysis is at risk for permanent muscle weakness, moderate exercise program, maintaining activity, healthy, balanced diet, nutritional status. If a statin lowering drug is necessary, make sure you use one of the ones that is least likely to have impaired muscle function. Have blood testing to make sure there isn't release of enzymes from muscle or liver that indicate those tissues are being stressed by these medications. So all of these things, it's a holistic approach to optimizing muscle function because yes, multiple factors can come together and compound the challenge for someone at risk for permanent muscle weakness. Perhaps I'll go to the next one from Jen. I've been diagnosed with hyperkinetic periodic paralysis. Gene testing done in 2016. Of the common genes, no variants were identified. My disease itself was severe in 2015 and in the early 40s. Can't even count the number of episodes that I live with. Now on medication, acetazolamide and hydrochlorothiazide, and I've learned to manage my triggers. I can function better currently. Although I do use a wheelchair for long distance walking. We have only one other confirmed case in the family, 16-year-old daughter. But there are many other families with similar issues. So I encourage everybody in the family to get genetic testing, even though a common variant in the gene test wasn't found. So thanks for sharing your story, Jen. It's reminding me about another way to try to confirm a diagnosis of periodic paralysis. And this applies specifically to individuals considering a diagnosis of hyperkalemic periodic paralysis. And my point is there's a lot of overlap in the clinical symptoms between hyperkalemic periodic paralysis, recurrent episodes of severe weakness and association with elevated blood potassium or ingestion of potassium salts can trigger an attack, and myotonia, either paramyotonia that paradoxically worsens with repeated episodes or cold, and episodic weakness. Myotonia does not happen in hypokalemic periodic paralysis, but it does in hyper. So for you, Jen, if things are very consistent with hyper PP, even though the gene test was negative, if you're looking for corroborative clinical data, perhaps you don't have symptomatic myotonia. You know, after a grip, you don't have problem relaxing, or you don't have stiffness in your legs when you get up to walk, or, you know, if you drink a milkshake, your tongue doesn't get stiff and thick and slurred speech. Maybe you don't have all those things, but your neurologist can do the needle electromyogram and look for myotonic electrical activity of your muscles. If myotonic discharges are found in you or your family members with other symptoms, that is very strong evidence that you are somewhere on the spectrum between paramyotonia congenita and hyperkalemic periodic paralysis. And that means you all should double down on your efforts to look for possible genetic basis. So, you know, hyper PP, from my perspective, that and paramyotonia congenita, those are sodium channel problems. In 2016, it's important to know whether whole exome sequencing of all the exons, there are 24 exons, not whole exome, but whole exon of the sodium channel gene, all 24 of them were sequenced. And everybody was confident there were indeed no known variants. It could be helpful, perhaps some of the other affected individuals in your family could have the same test. Now, if that still comes back negative, then you get into the realm of what would be called an unbiased genetic screen. So these gene panels, like the periodic paralysis panel from Invitae, it's a biased genetic screen. The bias is they're looking at 6 genes, 3 genes of which are particularly frequent in terms of causing periodic paralysis. There are other, gene test approaches. So whole exome, looking at all the exomes, is an unbiased approach. You're going to sequence all 19,000 genes. But the challenge is you're going to find lots of variants, on average 10 to 20,000 variants. So sifting through those variants is a huge challenge. But who would do this? Why would you do this? When could this possibly work? If you have a scenario such as yourself with a family with individuals who are clearly affected and clearly unaffected, and multiple people in multiple generations are impacted, then if your family is willing to send a lot of samples, then a research lab would be great. You have a very powerful opportunity here to do the whole exome sequencing and the unbiased screen, because we can look for association between these variants and who in your family is affected and who is unaffected. So, in a research perspective, you could perhaps get somebody excited to looking for an answer in that regard, and maybe something new would be found. So that's kind of where to go with, the scenarios such as yourself, where there's pretty convincing family history. Where else can I go if the conventional gene testing didn't show anything? And again, the screens are a little bit more sophisticated. They were pretty good in 2016. I will also comment, again, not to go too far into the weeds, but in one sense, we're lucky when thinking about hyper PP or hypo PP, because what we're looking for is variants that change the instructions for one particular amino acid to be put into your channel protein. So it's a missense mutation that we're looking for, because we know it's altered ion channel function that causes hyper PP or hypo PP, not complete wipeout of the channel. So with whole exome sequencing, you could find a lot of variants that destroy the gene, right? Or they're hard to interpret because they're far away from the instructions on how to make the protein. They're in the parts that control when the gene gets turned on or how the genome falls, really complicated things that could be tenuous explanations. And those you would have to chase down as possibilities if you have a disease caused by the absence of this gene being expressed. So the challenge is there's many ways to break a gene so that it just doesn't get turned on or it's not correct. And so that could be a problem in the hunt for disease-causing variants. In hyper-PP and hypo-PP, those are irrelevant cases. We're only looking for the variants that alter the function of the gene. So it helps our detective work hone in on how to try to interpret these variants of unknown significance. So again, I'm just putting an advertisement out there that in the proper context with the research laboratory, folks like Mike Hanna's group in London, Bernard Fontaine's group in Paris, were the big ones that we're continuing to chase down. These Louis Taychek used to do it in the United States, but he's kind of moved on to other disorders of the central nervous system. But these are the groups that could be excited about chasing down the basis of these rare atypical genes that might be involved.
So real quick, Dr. Cannon, to get a clear understanding is, so if a patient gets a genetic test and none of the known mutations are known genes that can cause periodic paralysis. So if it's not in the SCN4A, not in the calcium, and not in the one for ATS, are they still, is it possible that they could still have periodic paralysis? Or if it's not in any of those known genes, nothing shows up, should they consider looking into other conditions?
So if this is an isolated individual without other affected family members and there are any atypical features, I would look other directions and be open-minded. It's much more likely to reveal what's going on. Again, the case that makes this all just not quite so simple is for someone, multiple affected family members, multiple generations, all the same. My potassiums are low when I have an attack. The triggers are classical. My CMAP exercise test is abnormal, but still, I don't have an identified gene mutation. That situation, that person has periodic paralysis. We just don't understand the genetic basis. But the individual who's still on that journey looking for answers, a sporadic situation, no other family members affected, a couple atypical features, it's perfectly reasonable to do the periodic paralysis gene test because new mutations happen, so-called de novo. You might be the only affected person in your family because the way the egg or sperm was formed, you might have just been unlucky and had one new mutation. So it's possible, but if the gene test comes back normal, there is no variant in those three classical genes, and you're in an isolated situation, broaden your search, stay open-minded, consider other diagnoses. Don't have overly high expectations that the same recommendations for symptom management and periodic paralysis are necessarily going to work for you.
And when we speak about clinical diagnosing somebody clinically, because one of the other things that I want to make sure people are clear on as well, are those symptoms? Are those symptoms, if we're getting these symptoms later in life, I'm in my 40s and I'm having my first episode of periodic paralysis, because then if we're not getting the genetic confirmation, now we are relying on the clinical diagnosis. What is the clinical diagnosis in your eyes for periodic paralysis?
So there are published, I'll tell you right now, but there are published guidelines on this. There's the European Neuromuscular Center in the Netherlands that sponsors conferences on neuromuscular disease several times a year. And back in the 90s, Frank Lehman Horn from Germany organized a couple of these on periodic paralysis and myotonia, and the world's experts were there, and I was one of them, and we put together a consensus statement on what are the criteria for periodic paralysis. And you have to realize there's different confidence levels with those criteria. There could be a research criteria to enter a study, which would be the most stringent. There might be clinical criteria for, reasonableness for a clinician to follow a management plan, and then there might be, on the edge. So, the typical things that are looked for classical periodic paralysis are multiple attacks of muscle weakness. It can be generalized or local, usually symmetrical, generally has a relatively gradual onset over minutes or so forth. It's not like a fainting spell or an epileptic fit. Lasts for tens of minutes to half an hour or so with spontaneous recovery. While some people have very infrequent attacks, you need to have at least two. Just one does not meet the criteria. And then associated features would be other individuals in the family who have similar episodes. Usually the episodes begin in late childhood or puberty. Episodes may be associated with involuntary after contractions or stiffness of muscles, so-called myotonia. You may recognize association with trigger factors consistently after prolonged strenuous exercise, playing a whole game of full court basketball, sit down and then have an episode, or certain dietary triggers. If I, pork out on carbohydrates, have a big plate of pasta, then a half hour later, I have trouble getting up out of the couch. So consistent trigger episodes. So trigger events add to the clinical diagnosis. The exam is usually unrevealing, other than possibly detecting myotonia, except for very late stage in the disorder with permanent muscle weakness. There's no atrophy, no wasting. The reflexes are normal. The strength is normal in between attacks. So it's very challenging. There's nothing for even an experienced neurologist to see on the exam and strength testing. And then the other clinical feature for the clinical diagnosis to bring in are these electrical tests that can be done in the outpatient office of a neuromuscular specialist. So the needle electromyogram looking for myotonia that might be so-called subclinical or asymptomatic, but can be detected in the needle test, or the surface electrodes with voluntary contraction doing the compound muscle action potential, the CMAP exercise test. So those are all the features that went into the classical definition, the clinical criteria for periodic paralysis. Again, the hallmark is the recurrent episodes of weakness that are what gets called stereotype, means they similar events keep happening over and over again. And this is one of my episodes, is the classical feature. And a key element in making the diagnosis.
All right, we have, I think we'll take this last question really quick from Laura.
Okay. Do you recommend which lab to get whole genome or exon sequencing done? Personally, Invitae has done a wonderful job. I think, both in terms of not just technically, turning over the sample in a reasonable time, but also helping with interpretation and so forth. So again, I have no connection to them. I get no kickback from that, but just I know from a lot of experience with the program sponsored initially by Strongbridge and then Xeris and uncovering periodic paralysis, that they've reached out to me to help interpret variants. They've shared the information, and they do whole exome and whole genome sequencing as well. And it's a very high quality outfit.
I'm going to put that link in the chat again. so that they can, it's no cost to US citizens to have a periodic paralysis genetic test. It is in the chat again. So you will need a physician. It doesn't have to be a specialist. It can just be your regular doctor, your regular primary care doctor, but you will need a doctor to request it. But if you are here in the United States, it is no cost. So that is available for those people who are interested in the periodic paralysis actual panel. And then I don't have the information for the whole genome sequencing. Unfortunately, I don't know if Dr. Cannon has, but if we can, I'll try to see if we can't get that up on our Facebook page. And you're getting a lot of thank yous, Dr. Cannon. Let me see.
I would also thank everyone for participating and sharing your stories. Again, over the decades, you've been much better than any textbook in terms of learning what periodic paralysis is. And I really appreciate you sharing your stories. It helps a lot.
Thank you. Without doctors like you, many of us would have no answers. So we are very thankful to you for everything that you do for us, especially taking time out of your day to answer our questions today. And we will, again, this is recorded, and I think it will be up either today or tomorrow on our YouTube channel. So, you will have access to this information because I know there was a lot of it. I don't know if you were able to gather all of it. Linda says thank you. Trudy says thank you. Jen says thank you. They feel listened to, which I know is a huge part for us, is for someone to even take the time to hear what we have to say. So thank you so much, Dr. Cannon. And again, this will be recorded. So if you guys have any questions later on, you can also send them through Ask the Experts through our website. All right, good afternoon, everybody. Bye-bye.